This is a case involving a Lis-Franc ligament repair that was very delayed. The patient was playing pickleball and sustained the injury during that event. He went to the emergency room in which they took non-weight-bearing x-rays, which we know is absolutely contraindicated when you're suspicious of any type of midfoot injury. However, 2 weeks later, he went to his primary care physician, stating that he was still having considerable pain involving his left foot and that it was quite swollen at that time. The result was that the MRI had indicated that there was a Lis-Franc ligament subtle injury that involved a torn Lis-Franc ligament. There was dorsal lateral displacement of the second metatarsal on the intermediate cuneiform and slight medial displacement of the third met on the lateral cuneiform. Interestingly, there was no mention of a problem at the first met medial cuneiform, but on the radiographs, it is clear that this also involved the first met medial cuneiform, obviously making this a tertiary injury. So by the time that the patient was actively scheduled for the procedure, he was approximately 3 months out of the injury, and thus the indication at this point only could be an arthrodesis, which involved the medial and central column of Lis-Franc joint. We used a two-sessional approach. Here you see the first metatarsal medial cuneiform articulation being carefully dissected. Obviously, the saphenous nerve has to be preserved in this situation. Here you see distraction involving exposure of the first met medial cuneiform articular structures, which show considerable damage to the hyaline articular cartilage. At this point here, you see we're using a 2.0 wire pass drill bit to basically fenestrate the subchondral bone plate after early preparation of the hyaline articular cartilage with curettes. The next incisional approach involves the tarsometatarsal joints 2 and 3 of the central column of Lis-Franc joint. In this condition, both the second and third were involved in interarticular damage. The second involved a dorsal medial displacement. When the third is involved, the incision is made just medial to the second interspace. This then involves an incision that goes across the tarsometatarsal joint, proximal to around the midfoot navicular medial cuneiform joints to give enough exposure. The intricate part here is the soft tissue dissection. Initially, as the incision is made through subcutaneous tissue, care needs to be taken to identify the branches of the intermediate dorsal-cutaneous nerve, and these need to be carefully retracted with vessel loops. At this point, then, dissection is carried in the area for the second tarsometatarsal joint. This involves a direct incisional approach medial to the extensor digitorum longus tendon. This allows you direct bony access to this particular joint. It also involves medial involvement to the extensor hallucis brevis muscle and the underlying deep perineal nerve and artery, which is what needs to be carefully identified during this dissection process. Once the extensor hallucis brevis is identified, by careful retraction, the neurovascular bundle is also involved in the retracted process and will not be damaged in any particular way. Concerning the dissection for the third tarsometatarsal joint, this involves an incision just medial to the extensor digitorum longus tendon to the third digit and brings you directly at the third tarsometatarsal joint. With the incision being more lateral in the second interspace, this gives you a much easier approach to this joint. as we know, it tends to become convex at this point because of the transverse arch of the foot at this point. Again, the same situation, utilization of a Hinterman retractor with fluoroscopy to make sure that we're in the exact right spot. Curettage, again, is done along with subchondral drilling and also scalloping with an osteotome to prepare the joints. At this point now we move on to internal fixation, which includes the application of an internal compression screw and locking plate, which offers good compression to the first medial cuneiform articulation once it's anatomically aligned. We also restored the course of the Lis-Franc's ligament with a 4.0 cannulated screw. It was important that the second metatarsal base and intermediate cuneiform be properly aligned. Then a isolated screw through the second metatarsal and intermediate cuneiform was done. The decision was made then to use a compression staple at the third metatarsal lateral cuneiform articulation, which gave excellent compression. Excellent alignment was noted both to the medial and central columns upon completion of the procedure. Closure of the central column involved a retinacular horizontal stitch with 2.0 vicryl and then an outside 4.0 simple interrupted horizontal mattress nylon stitch. The first met was closed with a deep stitch of 2.0 vicryl, which involved the capsule and periosteal tissues, and then there was subcutaneous closure with also a 3.0 vicryl stitch, and then the skin closed with a continuous running nylon suture. Patient postoperatively was placed in a posterior splint with the foot and ankle at 90 degrees. Silver skull test did not indicate a significant equinus at this particular time. Then the patient will be seen in approximately 2 weeks for evaluation of incision. Sutures usually are removed at 3 weeks. The patient will be non-weight bearing for 6 weeks. Obviously, this will be dependent on the radiographs, and then the actual time of weight bearing begins usually at 6 to 8 weeks, and this will include a total of 12 to 14 weeks of immobilization, at which point then active physical therapy will be critically needed to restore function to the foot and ankle mechanics.